Welcome again for the medical student in this series of lectures in the cardiovascular disease. Our lectures, the topics of our lecture today is a congenital heart disease. Really, it will be in two separate lectures. First one is cyanotic heart disease. The second one is cyanotic heart disease. This an introductions of this lecture really present in about 1% of live birth, all the congenital heart disease, cyanotic and non-cyanotic. Most common category of congenital structural malformation in children is congenital heart disease, commonly divided into two. Non-cyanotic, it means left to right shunt, while cyanotic with cyanosis right to left shunt, based on the directions of the shunt. In common, the majority of congenital anomalies of the heart are present at the 6 weeks in intrauterine life, early development of the neonate. It's present in intrauterine life, and most anomalies compatible with the 6 months of intrauterine life, most probably it permit live birth at term. There is three main types of congenital heart disease. Type 1 is the left to right shunts, while type 2 the right to left shunts. The third one is obstructive lesions. The type 1 left to right shunt, what's called acyanotic heart disease, is present really in children frequent chest infection, about 6 to 8 times attack at first years of life. Tendency for increased sweating with the related their tendency to developing congestive heart failure, precordial bulge and hyperkinetic precordium. X-ray usually show plethoric lung field and cardiomegaly. The most common groups of this type 1 acyanotic heart disease is the ventricular septal defect, atrial septal defect, patent ductus arteriosus, and AV canal. This is ventricular septal defect between left and right septum, atrial septal defect between left and right septums, and the AV canal. There is freely communication for chambers of the heart, most common in Down syndrome, and the patent ductus arteriosus between the aortic arch and pulmonary artery. Really, the most common of this group 1, as we said, VSD, ASD, PDA, and the AV canal. And the VSD is a most common acyanotic heart disease in children, close spontaneously in 50% of patients. If you remember in the previous lecture, we said the most common congenital heart disease in all age group is the bicuspid aortic valve. The most common congenital heart disease in children is the non-cyanotic, is the VSD, while the most common congenital heart disease cyanotic is tetralogy of Fallot. ASD usually not symptomatic before age 30 years. Ductus arteriosus, as we say, this duct between the aortic arch pulmonary artery, remain open after birth for a while and then close. 90% of cases is isolated anomaly. Reversal of shunt flow due to the increase of pulmonary vascular resistance, and the shunt become from the right to left, then causes cyanosis. Prostaglandin E will maintain patent ductus arteriosus, and if we need to it maintain, like in the transposition of a great vessel, sometimes we give infusions of the prostaglandin E. If we need to close it earlier, we give the antiprostaglandin like endomethacin infusion. The fourth acyanotic heart is complete atrioventricular canal defect. All four chambers freely communicated, as we said, is the common in Down syndrome. The second group is right to left shunt. Cyanotic heart disease divided in two groups. First group is increased pulmonary blood flow. Second group, decreased pulmonary blood flow. In increased pulmonary blood flow, usually mild cyanosis, increased sweating, congestive heart failure, plethoric lung field in the chest X-ray, cardiomegaly. Most common is the TGA, transposition of great vessels on single ventricle and the tricuspid atresia with total anomalous of pulmonary vein. The second group is decreased pulmonary blood flow. There is a moderate to severe cyanosis, delayed and diminished second heart sound in pulmonary hypertension, accentuated P2, second heart sound. Oligemic lung field, the most common group, tetralogy of Fallot, and tricuspid atresia, and total anomalous pulmonary veins. And this is a tetralogy of Fallot, and one example of cyanotic heart disease. Will come to discuss this in details in the next lecture. The third group is obstructive lesion. Really absence of frequent chest infection, absence of cyanosis, absence of precordial bulge, presence of forcible and heaving cardiac impulse, systolic thrill and delayed second heart sound. ECG show obstructive lesions. X-ray normal size heart and pulmonary vasculature. The most common types of pulmonary stenosis, right side aortic stenosis, and coarctation of aorta in left side. I think we discussed an aortic stenosis and aortic valve disease. This is that the pulmonary in congenital heart disease, most common types of heart disease among children. If we take that the common cardiac disease in children is the congenital heart disease. As we said, about 0.8 or 2, about 1% of live birth. Most causes, underlying pathology is about 10% genetic. Example, trisomy 21st, Down syndrome. Congenital defect in parents or sibling is a greater risk factors. Types, as we said, left to right shunt, right to left shunt, and obstructing lesion. Also, to remind you, the left to right shunt, ASD, VSD, patent ductus arteriosus, increase pulmonary blood flow in ASD but no cyanosis. Increase RV, right ventricular pressure, and volume overload in ASD, patent ductus arteriosus. Hypertrophy and increased pulmonary vascular resistance due to the vasoconstriction to prevent edema. Over time, pulmonary vascular resistance increase more than systemic vascular resistance, so the shunt, it will reverse. This is what's called the Eisenmenger syndrome. We will discuss it later. While the right to left shunt, second cyanotic, decreased pulmonary blood flow or increased pulmonary blood flow. Decreased pulmonary blood flow cyanosis, blueness of skin and mucous membrane. Example, tetralogy of Fallot, great vessel of transposition, truncus arteriosus, tricuspid atresia, and so on. Long-standing cyanosis is associated with the clubbing of the fingers and toes. And this is a congenital heart disease with the cyanosis and the clubbing of the finger. A child with the tetralogy of Fallot with the central and peripheral cyanosis. While obstructions of the blood flow, obstructive lesion, as we said, coarctation, valvular stenosis, aortic and pulmonary, and complete obstruction is called atresia, like pulmonary atresia. Potential cardiovascular teratogenes in congenital, there is drugs and infection and maternal condition. Drugs, alcohol, amphetamine, anticonvulsant, and so on. Thalidomide, it was withdrawn from the medicine years ago. While infection like rubella, Coxsackie virus, maternal condition, old age group, diabetes, lupus, phenylketonuria, and other causes. Prevalence of heart disease in childhood is the cyanotic about 22%, acyanotic more common, 68%. While the acquired disease in the heart, this is a congenital disease in children. ASD, the most common, as we said. Cyanotic tetralogy of Fallot. Presenting complaint and sign and symptom in general. failure to thrive, exercise intolerance, easy fatigability, chest indrawing, sweating during feeding, bluish spills, otite spills, fever with rigor, palpitation, convulsion, fast breathing, edema, hepatomegaly, splenomegaly, clubbing in the cyanotic heart disease, long-standing cyanosis, focal neurological sign, other organ defect, chromosomal anomalies associated with. Cyanosis, is it a cardiac cause or lung cause? Sometimes we need to differentiate it. Hypoxia test. It means give neonate with a cyanotic congenital heart disease usually don't have significant raise in partial pressure, concentration of oxygen during administration of 100% of oxygen, while pulmonary cause it will be more better. Common cyanotic lesion, as we said, ventricular septal, atrial, and atrioventricular canal on other part. Syncope, syncope in the presence of, in the congenital heart disease, in the presence of increased pulmonary vascular resistance or severe left or right ventricular outflow obstruction, exercise may provoke syncope. As a systemic vascular resistance falls on the exercise, but pulmonary vascular resistance may rise, worsening right to left shunting and the cerebral oxygenation flow, and the patient complain of syncope. Pulmonary hypertension and Eisenmenger syndrome. Pulmonary hypertension and Eisenmenger syndrome in the congenital heart disease persistent raised pulmonary flow, example with the left to right shunt, lead to the increased pulmonary resistance, followed by pulmonary hypertension. Progressive change, including obliteration of distal vessels, takes place in the pulmonary vasculatures, and once established, the increased pulmonary resistance is irreversible. Central cyanosis appear and digital clubbing develop. This is what called Eisenmenger syndrome. The chest X-ray, the chest X-ray shows a large central pulmonary arteries and peripheral pruning of pulmonary vessels. ECG show right ventricular hypertrophy in Eisenmenger syndrome. If severe pulmonary hypertension develop, left to right shunt may reverse, resulting in a right to left shunt and marked cyanosis. This is what called Eisenmenger syndrome. In the congenital heart disease, from the left to right shunt and then increase in a pulmonary hypertension more than systemic hypertension, and the shunt is reversed, and so develop cyanosis and the clubbing called Eisenmenger syndrome. This is more common with the large ventricular septal defect or patent ductus arteriosus than with atrial septal defect. Really, with atrial septal defect is rare, even if not cause. Patients with the Eisenmenger syndrome are at the particular risk for the abrupt change in the afterload that exacerbate right to left shunting. Example, vasodilatation, anesthesia, pregnancy, surgery. Common cyanotic lesion, decreased pulmonary flow, tetralogy, and tricuspid atresia, and Epstein anomaly. While the common lesion producing cyanosis is this is the less common lesions. Non-cyanotic congenital heart disease, as we said, right to left shunt, ASD, VSD, patent ductus arteriosus. Now come to first our group is atrial septal defect. First group, acyanotic heart disease. This is the few preceding slides is the introductions for the congenital heart disease and its group and its most common presentations. Most commonly asymptomatic in atrial septal defect. Essential for diagnosis, right ventricular heave, S2 wide splitting and usually fixed. You remember this, wide splitting and fixed in the atrial septal defect. Grade 1, 3, or 4 systolic murmur at the pulmonary area, widely radiating systolic murmur mimicking pulmonary stenosis in infancy. Cardiac enlargement on chest X-ray. ASD, there's three types ASD. Ostium secundum and septum secundum, ostium primum 15%, 10% sinus venosus. So there is the most common is ostium secundum. Most common form ASD is a fossa ovalis, really a large defect, considerable shunt of oxygenated blood flow from the left to right shunt, mostly asymptomatic. The second heart sound is characteristically widely split and fixed. Situated in the lower portions of the atrial septums, atrial septal defect, primum, situated in the lower portion of atrial septums, and the overlies the mitral and the tricuspid valve. In most instances, a cleft in anterior leaflet of mitral valve is also noted. Combination of left to right shunts across the atrial defect and mitral insufficiency. Clinical feature similar to that of ostium secundum atrial septal defect. Atrial septal defect, three major types, as we said, to remind you: ostium secundum, ostium primum, and sinus venosus. Ostium secundum most common in the middle of septums in the regions of foramen ovale. Ostium primum lower position, form of AV septal defect. Sinus venosus least common, positioned high in the atrial septum, frequently associated with total anomalous pulmonary venous anomalies. Atrial septal defect, the chest X-ray, enlargement of the right ventricle, see the directions of the right ventricle up, while if enlargement left ventricle, the direction is the down there. Enlargement of atrium, large pulmonary arteries, this pulmonary artery, left atrium enlargement, increased pulmonary vascularities. Treatment of atrial septal closure generally recommended where ratios of pulmonary to systemic blood flow is 2:1. Pulmonary 2 and systemic circulations 1. Operation performed electively between age of 1 and 3 years old. Previously surgical, nowadays closed by interventionally. I mean by in cath lab put a occluder to close this atrial septal defect. Secundum ASD are well tolerated during childhood. Antibiotic prophylaxis for isolated secundum is not recommended. Previously we give. I think in the lectures of endocarditis you remember the indication. It's isolated ASD, we not give prophylactic antibiotic. Surgery for transcatheter device closure is advised for all symptomatic patients and also for symptomatic patients with the pulmonary systemic ratios flow 2:1. Ostium primum defect are approached surgically, difficult to be closed by occluder. What interventions means? Small ASD don't require intervention. The easiest way to decide if the shunt is small is by echocardiography. The shunt is not creating right ventricular volume overload. Then one can assume the shunt needs no further evaluation. For large defect, those with the RV volume overload, surgery can be done at a very low risk. Surgery involves anything from the simple stitching of the foramen close to that, the patching of the hole with the dacron or the pericardial patch, anomalous pulmonary vein connection, or the baffle to the left atrium through the sinus venosus defect when such anomalous veins are present. For the ostium secundum ASD, percutaneous closure in cath lab by use of variety of devices is now preferred over surgery. The percutaneous closure devices often resemble double umbrella that look at the septum between the dacron umbrellas when open. This is through the catheter and push this device to close the atrial septal defect, mainly secundum. Better than surgery easily and need not for anesthesia. The second subject in the group of acyanotic heart disease is the single ventricular septal defect. As we say, single most common congenital heart disease malformation is accounting for almost of 25 or 30% of congenital heart disease. Defect can occur in both the membranous portion of the septums, most common membranous, and the muscular portion of the septum. This is a VSD position of the classification of the VSD. There is a type 1, type 2, type 3. Type 1 membranous septums. Some called it paramembranous or perimembranous defect or infracrystal. Some called subaortic, conoventricular. Type 2 muscular, which is the most common type. Inlet, trabecular, central, apical, marginal, or the Swiss cheese. All these the same. It's a muscular type ASD. Epinomes. This is the eponyms of the congenital, muscular type VSD. Type 2, type 3 outflow septum defect. What called supracrystal, subpulmonary, infundibular, or the conoseptal. Septal deficiency, AV septal defect, AV canal sometimes associated. Ventricular septal defect, three major types, as we said in the summary: small, hemodynamically insignificant. Small ISD, between 80 to 85% of all ISD. As we said, most of them, about 50% or more, close spontaneously. Less than 3 ml in diameter. All close spontaneously, this symbol. 50 by 2 years, 90 by 6 years, 10% during the school years. For most of this is called, close spontaneously. Muscular closure sooner than the membranous closures. The moderate VSD, second type, 3 to 5 ml in diameter. Least common group in children, about 3 to 5%. Without evidence of congestive heart failure or pulmonary hypertension, may be followed until the spontaneous closures, and most probably about more than 50% it will be closed. Large VSD with a normal pulmonary vascular resistance, 5 to 6 to 10 millimeter in diameter, usually require surgery. Otherwise will develop congestive heart failure, and it follow and most probably at the age of the 3 to 6 months, and it might develop Eisenmenger syndrome later. Ventricular septal defect clinical finding, grade 1 ila grade 4, grade 6, medium to high pitch. The grade of the murmur from 2 to the 6, medium to high pitch, harsh pansystolic murmur, which is covered than the S1 and S2 murmur. Here paced at the left sternal border with radiation over entire precordium. This is the pansystolic murmur. Treatment of ventricular septal indicated for closure of VSD associated with congestive heart failure and or pulmonary hypertension. Patient with the cardiomegaly, poor growth, poor exercise tolerance, or other clinical abnormality, and the ratios of the 2 to 1 typically undergo surgical repair at the 3 to 6 months. This is the failure to thrive and with pulmonary hypertension. This is the pictures of occluder, as we said, to close the VSD or ASD like umbrella and enter through the catheter in the cath lab. Patent ductus, few words about patent ductus arteriosus. Small defect, no symptoms. Large defect, wide pulse pressure, a large heart in the chest X-ray, thrill in the left second, in the second S1, and the continuous murmur. X-ray prominent. The murmur is the machinery and continuous. X-ray prominent pulmonary artery with increased vascular marking. Account for about 10% of all cases of congenital heart disease. High incidence of patent ductal arteriosus in infant born at high altitude, over about 10,000 feet above the sea level. More common in the female than male. This is the aortic arch and pulmonary artery. This, if it's obstructed, becomes ligamentum arteriosum. If it's become patent, so patent ductus arteriosus. A clinical finding and closure depends on size of shunt and the degree of associated pulmonary hypertension. Pulses are bounding and pulse pressure is widened. Characteristically has a rough machinery murmur with the peaks at S2, second heart sound, and become decrescendo murmur and fades before the S1. And the treatment of patent ductus arteriosus consists of surgical correction with the PDA is a large except in patients with pulmonary vascular obstructive disease. Transcatheter occlusion of a small defect has become standard therapy nowadays in cath lab. In a preterm infant, we want to close it. Indomethacin is used 80 to 90% success in infant more than 120 grams. Thank you for the active participation. See you soon.